According to the ESRAS clinical survey, over past years, the number of delegates finding 10 degrees or more of rotational error acceptable decreased from 52% in 2014 to 34% in 2018, which is, I think, good effect, huh? So what are your key pearls to minimize intraoperative and postoperative rotational error? Doug, what do you do there?
First of all, it's going to vary according to the IOL. I mean, you can go through all the alignment processes. You've done fantastic work on different methods of alignment. We've found that very meticulously perform manual marking can be as good as the automated. That said, we have an automated system being installed in our operating room this week, and I can't wait to use it. But intraoperatively, once you've gotten it lined up, you know, it depends on the IOL. I mean, certain IOLs, they don't rotate. You put them there and, you know, you have difficulty rotating them, in fact. And there are others that are more readily, can be rotated readily and can move postoperatively.
We know that some of the hydrophobic lenses unfold very slowly.
Right.
So what would you recommend? How long do you have to wait? It can be very, depending on the temperature actually in the surgical room, how long it takes.
Yeah, I look for I look for the IOL to be the optic completely unfolded. That's a great point, and I look for that stability. And I don't have a way to gauge it visually other than that. It's probably not very satisfactory.
Okay. All right. I think, Thomas, you have a special way to deal with this, isn't it?
Yeah. And first of all, I think one message is, Doug alluded to this already. You need to take out the viscoelastic substance behind the IOL. You need to make sure that everything is gone. That's in my opinion.
Is there anybody who would leave it behind then?
Sometimes I see this, but I'm just saying that right. I think it's important.
Okay.
But once you have it out, then the rotation can be. So you have the eye. We usually write it 5 degrees off. We do manual marking, but also we do digital. We do digital for many years, and I think it's working very well for us. Then I bring this lens into position, but I take then much more time. I need to make sure that, first of all, the eye is pressurized, that I have a certain amount of degree, 15 to 20 millimeters of mercury, and then I really do the same like Doug said, I push the lens, and if I have the feeling that the lens sits on the exact axis, I'm happy. But then I do one other thing which I haven't done a year ago. I get all my patients from there, I bring them in a room and I let them lie down for at least an hour. Because we know from studies, there's a beautiful study from Japan, that the rotation in the first hour can be pretty high. And if patients run around and they get their drops and do other things, we haven't done a study, we're just starting to do this, but my number of re-rotation have dramatically come down. I almost don't do them anymore. So I let them lie down, close the pupil with a myotic, and I think that this is an effect of keeping the lens, particularly the hydrophobic lenses, in place.
I think that just Oliver Findle showed in the study, you know, that most of the misalignment occurs in the first hour after surgery. Now there is one specific group where we have to be very cautious. That's a patient probably who has quite some myopia.
Yeah,
does it make a difference? Because there are some conflicting reports on that, whether it makes a different actual length and stability.
It's sort of commonly said, high myopes, they rotate more, but in fact, the anatomical studies show the size of the capsular bag in the high myope may not be any larger.
Yeah. We didn't find it in our cohort, I must honestly say. So.
Yeah, and I think it's more the IOLs that are aligned vertically. And the axial myopes more often have witherul astigmatism. So I think that's sort of the confounding factor in that. The other thing that I do in these patients is I look at them, if their vision is not great one day postoperatively, I dilate them and check the position of the IOL. And if the IOL is off, I will actually go in with a 30 gauge needle at the slit lamp and rotate it back into the right position. And it works quite well, and I've had to do it only 3 times. And the beauty of that is the 3 patients I've done, I haven't even really remembered that I've done it. You know, you're just so quick.
But if they have rotated, you know, like 9 degrees, or let's say if you're really off because you had not marked it correctly, that can also happen. But it's not a big disaster. What I would then usually do is I wait a little bit. I do the rotation at 7 to 14 days because then the capsular bag has fibrosed a little bit and then the lens stays more. Assuming that I had it right and that there was really a big rotation, which is very rare now. But I would then recommend to wait a little bit before the fibrosis, then the lens usually you only have to do it once, never
Yep.
twice.
So when you have implanted the toric IOL, Doc, and the outcome is not as predicted actually because there's some residual refractive error, how do you address that? What is your strategy there, what you're going to do to the patient? It's of course dependent on what you find there in terms of refractive error.
Absolutely, and it's really the same conversation you have with any IOL patient who's not where they want to be and has high expectations. You address the residual astigmatism either by rotating the IOL. You hope that you pick the correct IOL in terms of the toricity. You may do a PRK or a LASIK on them. You may have to exchange the lens if it's way off. I mean, there are complex eyes where you put in a toric IOL and you get in there and get everything measured post-operatively, and the patient might be a diopter of myopia, and they need all this astigmatism, and you might decide, and the patient might prefer, in fact, to have an IOL exchange, because for some patients, that additional step means I didn't get the right IOL. I have the wrong lens in my eye. And there's a psychology to it as well, and there's also a cost factor about whether or not it's something that might be covered by who's going to pay for it.
Yeah.
So this is one of the points, that some colleagues actually don't want to incorporate these toric IOLs into their armamentarium. How often does it occur, Thomas, in your
I think,
hands?
as a rule of thumb, if the post-operative outcome, the spherical equivalent, we do the refraction, you do the refraction post-operatively, and it's ametropic, and you have a plus half a diopter with 1 diopter of astigmatism, then usually the rotation gives you the perfect outcome. If it's minus half, so if basically the outcome is spherical equivalent is minus 1 diopter altogether, then the patient, even if you address the astigmatism, the patient maintains myopic and then is not happy. Then you have to talk about either take the lens out or do this touch-up of PRK. And you just saw PRK, LASIK, or this. But if you ask me how often that comes, with the new formulas in the presbyopia, it has presbyopia correcting IOLs much less. I do it very rarely now. I would assume...
Less than 1%?
Yeah, 1 or 2%.
Yeah, so the
That's what-
anxiety for
Yeah.
having problems actually is not very realistic. Is that true?
As long as you're doing a good job preoperatively, intraoperatively, it really is a decreasing number. And sometimes you have to say to patients, there's some patients, if they're 20/20 plus and they want to be 20/15 and they have a tiny little bit of astigmatism and myopia, you have to say, I could operate on you and I could make you as easily I could make you worse as better.
Yes.
And you have to be realistic in how you lay it out for them.
So in the whole picture, where is the most noise here in the toric IOL? Is it the preoperative measurements, have them correctly? Is it in the misalignment? Is it in the incision, the surgically induced astigmatism? What do you think?
I think
Where
it's
is
the
most
pre-op.
noise?
I think it's in the pre-op measurements.
It comes all back when we are at the end of the procedure. Now we're talking about the outcome for the patient as this re-rotation. It all comes back if you don't put enough work at the beginning in your patients with counseling, with talking, with preoperative measurements. At the end, a little bit you pay the bill yourself because you don't have the outcome. So, but if you do all these steps, as we pointed out, I think it's only 1, 2, 3% rarely that you really have to do something.
So I think we can summarize that clearly there are a lot of factors, preoperatively, intraoperatively, and postoperatively, that contribute to visual quality, acuity, and patient satisfaction with presbyopia correcting and toric IOLs. I hope that today's discussion will help you implement best practices and understand the importance of acquiring precise preoperative measurements with advanced diagnostic technology for astigmatism and presbyopia patients. This has been the EUCRS webinar discussion on refractive IOLs. Doc, Thomas, thank you very much for participating.
Thank you, Rudy.
Thanks, Rudy.